Welcome, everybody. Thank you very much for this opportunity to present to you at your Brain Awareness Week. So I'm Jo Wilmshurst. I'm a child neurologist in Cape Town, South Africa, and I work for a number of international organisations, including the International Child Neurology Association and the African Commission. But my place of work is actually in the Red Cross War Memorial Children's Hospital in Cape Town, South Africa. So these are my disclosures. So the theme that we're going to talk about is really how to optimize becoming a researcher, how to optimize becoming a good doctor. And in order to do that, we need to consider our goals for appropriate child health. This includes prevention, early recognition and intervention, diagnosis, and chronic care of our patients. We can't do this without having adequate training and education. And only with this in place can we, in fact, be effective as researchers, where we must undertake effective epidemiology and audit of our practice. And only with these things in place are we then equipped with the skills to undertake advocacy, lobbying, and stigma. So for the patients that we care for, they're affected by the background setting that they're born into, the direct influences that affect them as they grow up, what can be done to help them, and their overall genetic makeup. And compounding the care that we wish to offer our patients is that we often have completely ineffective preventative care practice, massive burdens of diseases, especially in our settings, disparities between rural and urban and public and private facilities, huge stigma, especially in the area of epilepsy, problems with access to facilities, sustainable supply of treatments, and then challenges that come up over and over in all the communications I have with people about training across all levels of care. So what could be approached to improve our ability to undertake effective research? So this is a very nice approach that was described by this group looking at low and middle income countries. And what they really highlighted is that it could be broken down into three areas of key need. So you have your macro and institutional level, you have your operational level, but it starts with the individual, it starts with you. So when we're talking about the individual needs to have awareness of trials and research in general, needs to be motivated to lead and work on trials, needs to have knowledge and technical skills, and needs to be able to then take on trial leadership capabilities in order to do effective research. And only with this in place can you then make that stepping stone of forming those collaborations to improve how you acquire the resources that you're operating with, to be inclusive in the planning of processes of trial operations, and then to start making changes for policy of relevance and uptake. And only with this in place will you then have that knock-on effect of changing your macro and institutional levels of functioning. So examples of how we might think about strengthening capacity. Obviously, research is top of our list to understand our populations, what we do, and how we can do things better. But you need to remember that you need to do this well. You have to have effective education, training, and also be able to network and link up with other bodies. So this is an illustration of some work we've just finished through the African Commission and Pediatric Commission of the International League Against Epilepsy. And we looked at the last 30 years of publications that have been undertaken in the field of epilepsy from Africa. And what you see is that there's been an impressive improvement in the number of publications that have come out in each of these 10-year periods. The areas in green in the histogram are where there was first or last author representation from somebody based in Africa. And in blue, there wasn't. And I think it's a bit depressing that although the numbers have impressively increased, we're still seeing quite a large chunk where we're lacking African leadership in research that's happening within the continent. When we then look at the map on the side of Africa, this then gives you a density of where the research is actually happening. And you immediately see that there are certain countries such as Nigeria and South Africa, where you actually, in some of the East African countries, where there's a clear, active and enthusiastic takeoff in research that's happening. But when you get to some of the other countries, there's anything from none to only 5 publications on epilepsy over a 30-year period, which is really, really worrying. So research and collaborative work can be incredibly exciting, and there are some really, really great examples. And I want to start with putting these in because this is the kind of examples I think we should be aspiring to. So some of you on the call may already be part of this muscle project, the ICG-NMD, which is linked with groups in London and other parts of the UK, but is also a multi-center project across 5 countries from South America to South Africa and Zambia, India and Turkey. And that's exploring and understanding muscle disease and trying to develop a database and phenotypically identifying cases to help us improve our management, as well as training doctors so that we have sustainable infrastructure at completion of the study. The EPINA study that's been rolled out with colleagues in Ghana, Kenya and Tanzania is also highly innovative. So it's got UK collaborators, but the main aim of the project is not just for understanding epilepsy in these regions, but it's also training up and improving to get targets of making the diagnostic and treatment gap reduced. And then a very similar project, but more siloed, is occurring in Nigeria. And this group is looking at training up community healthcare workers. Again, a very exciting collaboration with Vanderbilt University and working with colleagues in Nigeria with very much equal representation across both groups and great plans for sustainability. So these are really good examples of good collaborative projects. So let's go back to thinking about what are the challenges that we face in our setting, especially in the field of children and those with epilepsy. So when we look at the reality of our practice, this was some work that we did a number of years ago. First of all, investigating what's the capacity to deliver neurology services in general, and then we siloed it in to look at what are the challenges for epilepsy with these people from 34 different countries. And what immediately became evident is that there's not enough doctors. So when we looked at the countries that we could sample for a population of 148 million, for a population of 927 million, sorry, there were only 148 clinicians who were in the field of caring for children with neurological problems. And I put it that way around because, in fact, some of the countries that seem to have larger numbers, they made it very clear that these were often pediatricians or people with an interest, but they hadn't had the opportunity of formal training in child neurology. So there's a huge need for training across the continent. And messages that came through is obviously they needed better help with more facilities, more access to anti-seizure medication and screening tools. Lack of access to good EEG was a big problem. And for education, so again, this isn't just at the tertiary level, but it also spans upskilling at primary and community and undergraduate as well. And likewise for training itself. Lack of specialists is not the only issue, that we need to think about improving skills for doctors, nurses, ancillary workers, technologists, rehab people, the whole team that would be involved in caring for patients with neurological disorders, including epilepsy. And that we need to think about innovative approaches that are relevant in our setting. And the use of oral phenobarbital is one project that we've certainly explored. And then working with traditional healers is another resource that I think can be done well. So let's think about approaches. If we address the question that you put to me of how do we improve research, especially in the field of epilepsy in Africa. So I would start, I'm going to give you some examples of some of the projects that I've been privileged to be part of. And I would start with saying, understand your population, that you should get in the habit of keeping good registries, which are ethical and secure. It'll give you then the opportunity to explore what might be unique African questions that are specific to your needs in your setting, and to research areas following on from this that are highly relevant to your practice. So much of the work that you'll see that I'm going to tell you about just now is highly clinically relevant, that it helps the practice that I work in, and that I hope it helps the teams that I work with deliver better care. So these are some examples. We started with just screening who do we see with epilepsy in our service, and how does that compare internationally? And we rapidly realized that we weren't delineating our patients as well as we should do, and we totally restructured how we screen our patients when they come in through our epilepsy services, and actually formatted the tracking using a very standardized system developed by the British Pediatric Neurology Association called the Describe system. That's now part of our standard care, and it's improved our delineation of our patients significantly. And then looking at specific population groups, HIV's pandemic proportions in our setting. So we wanted to understand how do seizures affect these patients and how can we give better care. We also have huge problems with many children with multi-layered conditions. So the risk of them suffering osteoporosis, both by their underlying often lack of mobility as well as the drugs they're on, meant that we were worried about whether they needed access to vitamin D, which indeed many of them did. And then lastly, it doesn't have to be the rare and wonderful conditions, that in fact also we need to be aware that conditions occur in Africa as well, such as tuberous sclerosis complex. And this study really highlighted to us that we were only seeing the tip of the iceberg of how many children had tuberous sclerosis complex. It also helped us with targeting our approaches to their epilepsy care. So once you have this information, it doesn't just stop there, because now you have this foundation of knowledge. It then raises more questions, and then it gives you the opportunity as stepping stones to do the follow-on studies and to start working with teams and actually improving the care and auditing what you're doing even more. So we had the problem a number of years ago where we previously had access to ACTH when we managed our children with epileptic spasms, and that product is not available to us anymore. So we had to think out of the box and investigate what was the evidence for using oral corticosteroids and alternate hormonal therapies, and then to try and work out how could you then safely integrate it into a lower middle income setting. And it was an extremely useful exercise to then set in place a protocol that we could then follow. Similarly, when we bring children in for EEGs, we don't have the capacity, as happens in international settings, of keeping them there for the day or doing routine telemetries. That's a scarce resource for us. So we need them to sleep. We need to get accurate recordings. And we reverted to using melatonin, and we wanted to audit if it worked well. And in fact, it's highly effective in our setting for our patients. So what about other unique tools that could be used? So the field of apps and remote devices is truly established in the international sector, where most parents have smartphones and internet access is not a challenge. And we wanted to interrogate whether this could actually be viable or useful in our setting. And it was certainly useful for us for collecting the information that we could get from the families, but we also learned very quickly what many of the barriers and issues were for trying to implement this in a resource-limited setting. Cannabis, I'm sure many of you have been pestered by families wanting access to, at the very least, CBD or making their own homemade variety. And at this point, we were really worried because, in fact, many of our practitioners were as confused about the role and the use and the formulations. And so putting this together with a team to actually guide clinicians was an extremely useful practice to tell them what's safe, what isn't, and where there's evidence where CBD in itself might work. And then something very close to my heart is about promoting training. So EEG is a standard resource in international settings, whereas where we work, we need to be very careful that the tool is used appropriately and accurately. And upskilling ourselves in safe EEG practice is paramount. So we've been working, this Veena Kanda is my senior clinical EEG technologist who has a special interest in training. And we've been developing apps and resources and handbooks to improve how people do basic EEG skills and functions for children. And we've been auditing ourselves. And as we've been auditing ourselves, we've been strengthening and improving on the handbook and the resource. So she's in fact doing a PhD on this work now, and is hopefully going to be able to consolidate the curriculum to have a really useful resource for pediatric EEGs in our setting. So, and what about other common conditions that we manage, such as status? So the reality is that most children present to us in established status. So it's not surprising that we commonly get problems with benzodiazepine resistance. And this has been really exciting. It started with a study at the bottom where we explored what was the best therapy to give in our setting after 2 benzos had been given. And we established that in our setting, parental phenobarbital, it was in fact the agent that worked best. But we then wanted to understand why we had so many benzodiazepine resistant patients that ended up having to go on to that second stage. And then this was collaborative work that started with a medical student at the time who subsequently qualified and done a PhD, Richard Berman, and he's been based now in Oxford, and with a combined group of teams between UCT and the Oxford group, this work was put together where we looked at understanding, starting at the bench and then moving into the clinic, what are the processes of status that specifically affect us in our setting? And they put forward some great recommendations. So as I started alluding to at the previous studies, building collaborations and working with equally interested and motivated colleagues can be incredibly exciting and powerful. It can also help you get funding and better resources for what you want to do. So these are some examples of some work that's come out in the last few years, because COVID, unfortunately, has not gone away. So we use this as an opportunity to actually look at how can we improve the care that we give. And certainly using remote systems have been an area that we've definitely had to upskill ourselves in, just also for patients and telemedicine and teaching. But also for guidelines for people in the setting of COVID, of what was safe and what wasn't. And this was from a working group that we were actually working on a different project and then realized that COVID was more important and sidetracked ourselves to actually put this report together. And what about groups across Africa? So some incredibly exciting collaborations have worked just with linking up and communicating with each other and really kind of putting the face map down, the footprint down to actually say, we need to have epilepsy surgery. What are our problems and our barriers? Why are there so few clinicians? And how can we actually start looking at upskilling and improving access to more training? And then further working groups. So this is a great project that we did looking at epileptic spasms and understanding from the beginning through to where we are for why we deliver care and what we understand of the condition. What are the barriers to epilepsy and why do we have so many problems and challenges, especially in the poorer regions of the world? And then the project below was looking at definitions for neonatal seizures. And the great thing about this was that we took the project and it worked through from where you had the resources of being able to do continuous EEG in a neonate through to where you have nothing and just observation, and how accurate can you be in producing these kind of guidelines for definitions. Genetics. Genetics is something that we don't have enough access to and that we should do. And so we've been doing collaborative work between the states and through UCT, where we've been trying to upskill and improve access to epilepsy genetics, and then using that with a clinical application. So Elena Esterhuizen, that you can see is first author for these 2 papers, is doing a PhD in this area. She's a molecular scientist. And what she did was she set up in-house in UCT a next generation sequencing system, but started with looking at Dravet syndrome as a condition that we figured was critical for early recognition and early diagnosis. And what we did was we confirmed a cohort that we suspected had Dravet, and then we backtracked from the definitively confirmed cases. What were the key clinical findings in our group that would allow us to have red flags to tell people who don't have access to genetic testing, these are patients that are highly, highly at risk of having Dravet syndrome. So there are many, many tools available, but these were markers where we had 2 key areas, and that was the presenting at a young age. So we found under 6 months of age and with prolonged febrile seizures, they were typically recurrent. And just by saying those 2 markers alone, which in our setting is often quite challenging, but that 6-month cutoff for us was critical, we realized was actually giving us a gateway of having a clinical tool to actually help us identify patients and intervene early. And likewise, staying up to date. So working with this group with the bottom paper of understanding what are new products that are coming in, what are things that we may not have available to us in our setting that actually we should be aware of and we should be motivating for, that would make a huge difference to care. And then working with colleagues in other parts of Africa can be also incredibly exciting. And this is in fact an ex-trainee of ours who's now professor in her department. And she's in the process of doing a PhD, looking at not just understanding her epilepsy population in Kenya, but also exploring novel interventions such as the ketogenic diet in this setting, which traditionally has been viewed as very challenging in Africa. But actually, I think we're doing a paradigm shift and demonstrating that it can be done. It can be done really well. So to actually move forward, you've got to give quite a lot of yourself as well. So you need to be willing to give up your time and to work with key associations to actually help them. And so the International League Against Epilepsy is an obvious one for the field of epilepsy. It is a lot of work, but I promise you, you'd learn so much from working with these groups. And you also meet some fantastic collaborators that lead to both more projects and often become mentors for you. So these are some examples over the years of projects that I've been privileged to work with. So we developed the infantile seizure guidelines. We understood what common practice was for treatment around the world. We developed a systematic review to give guidelines of ADHD in children with epilepsy. We identified issues of behavioral and neuropsychiatric problems in people with intellectual disability and epilepsy. We understood where guidelines were lacking. We have just finished putting together the classification for neonatal seizures, and we're in the process of finishing off the latest updated recommendation for treatment of neonatal seizures, and working with the advocacy group when the initial World Health Assembly resolution was passed, was incredibly useful for seeing how that could adapt into resources for child health. And now, of course, there's the IGAP coming through, so it's even more exciting. Establishing guidelines for epilepsy surgical centres. And what's great about all of these is that by having representation on a global scale and also on a country, high income, low income setting, you get the voices of people rationalizing and saying this is an appropriate statement, or this won't work, or we need to actually find ways around this. And then for improving education in epilepsy, the International League Against Epilepsy is developing its epileptology curriculum. And as part of that, through seminars, it's been very exciting developing various learning texts that are accepted by the League and fit in with their line with definitions and curriculum content for these particular areas. So thinking about collaborations, how do you move forward with strengthening your collaborations? So there are pros and cons, inevitably, especially with the links with high income and low income settings. The pros are that it can be a really effective way for centres to work together, and that even resource equipped settings can learn from resource limited settings, that capacity can be improved if the programmes are addressed strategically. But you need to be a little bit careful, because it can be really undermining if it's done without sensitivity and careful planning. And what you don't want is the situation where a centre from overseas says, we're coming in to tell you how to do this thing, and they do a flying visit and they do a lecture roadshow, and it's their opinion and there's no real translation of the knowledge that they're giving. So imparting the knowledge or recommendations that lack insight into the local resources can end up as being just demoralizing and widen the gap. So what would be ideal when you're contacted by a centre overseas that says, let's collaborate? You need to make sure that they understand the local setting and the needs and capacity. So that centre must be prepared to have at least a detailed conference call, but ideally come and see you and meet all the stakeholders in your centre to actually ask what your outcome aspirations are. So to agree on realistic goals, timeframes, and who are the target people. And then to have a strong relationship with you. So the local team, you should lead the requested areas for upskilling. But you need to be flexible. Don't start too high. Don't start asking for epilepsy surgery when you're still trying to set up your EEG service. And then to work in stages and think about the tools of education, and that a blended approach is great. So develop and identify available online resources, look for key mentors that you can work with to have small groups of individuals to promote their skills, and then to remember that they should come back and they should keep the contact. And as your areas evolve, then the team might need to adjust according to what your needs are. And then the clinical tasks, should be led by yourselves, by the local team, and indirectly supported by your collaborator. And that the aim is that you want to have a standalone, sustainable skills and practice that results. And to remember, this is not going to happen without funding, that you need to monitor and evaluate what you're doing to make sure that you're doing it right. So I want to just sidestep a little bit into training, because none of this is going to happen well unless you have effectively trained individuals in your setup. So the problem is that most of the training capacity in Africa is based overseas. And as we know, this leads to the brain drain. So this is a program that comes out of the center I work in at University of Cape Town. And it's called the African Pediatric Fellowship Program. And it's aimed at developing a strategic workforce to strengthen pediatric healthcare for Africa in Africa. And what we've done is we've tried to develop a generation of clinicians, educators, and leaders who are equipped to transform child health in the African context. So we can train them in clinical skills, but actually when they come, they have opportunities to have far more. They're giving opportunities to develop themselves as educators. They're given research skills. They're encouraged to be advocates and leaders, and opportunities to collaborate. So we found that the nested training is quite intense, but actually the real work starts when they go home. And what we're doing more and more now, the program's been running for about 12 years, it's the post-fellowship support, which is probably even more exciting. And the collaboration with our APFP alumni and their centres to develop these specialist and subspecialist training across the continent is the next goal of where we're going. So the work and the health system development that they are doing is they go back and then they ask us for what the needs are and what areas we can help in. So in fact, there have been over 200 fellows that have either trained or been training across diverse areas. So this isn't just about epilepsy or neurology. And we've got partnerships in 14 countries and over 50 sites with over 90% retention rate at 1 of 5 years. And that's unheard of with the figures around the brain drain. And when we did the review in 2020, we were at 150 then. And you might be wondering, what about neurology? So we've had 9 pediatric neurologists completed, 4 developmental pediatricians, and 1 of the 2 techs trained in neurophysiology. And so where did they come from? And so you can see here on the density map, we've got some quite nice hubs for East Africa and for West Africa, and obviously sub-Saharan Africa, to the extent that in Kenya, there's kind of a Kenyan APFP. And in West Africa, we're hoping that Ghana, in fact, will be the first one to take off with getting its own independent training happening. And as I showed you earlier, Africa often has a bit of a bad name about its number of publications. Well, these guys are prolific, so they're exponential numbers of publications coming out from them. So you might be wondering about neurology. So we've had trainees that have come through from 9 countries, and we've got another 4 at the moment in the pipeline from Sudan and Tanzania, Mali and Zimbabwe. So what do they do? What's so great about them? So this is the newest trainee to go back from Uganda. This is Robert Sabunya, and he went back in 2019 and he completed his master's in Lancaster. He immediately went back and hit the ground running. So there were 2 other pediatric neurologists in Uganda. So he went to join their team and restructure the services, got MDT services happening, which is a rarity in Africa, developing EEG services, and was awarded the Child Neurology Society, which is the North American body, Bernard D'Souza Award. It's Edward Kija, he's from Tanzania, and he completed in 2015, also having done a master's, and you saw his paper was published. That was the one on vitamin D, and also went back, hit the ground running and set up services, and has been supervising master's students, is a member of the Education Commission for the League, and is also on the International Child Neurology Association, and has set up multiple international collaborative projects, and has also been awarded the Bernard D'Souza Award. And then Charles Hammond, he's from Ghana, also completed his master's and published it. He was in fact prolific when he was with us. He did multiple publications. He also serves on the League and has done various leading postgraduate studies, set up EEG services, numerous education programs, and was also awarded the Bernard D'Souza Award. And Pauline Samia, so she completed with us, she was our first trainee, also did a master's and is now in the middle of her PhD. She's been secretary of the National Association. She's been on various committees for the League as well as the International Child Neurology Association. She's been integral in setting up the pediatric neurology curriculum in Kenya. And she's also served as chair for her department and is a founder member of the East African Academy of Childhood Disability. So that is what they can do. And that's just the tip of the iceberg. So these guys are lobbying for access to therapies. They're members of international groups. Their research is exponential. They're establishing services where nothing existed before. They're creating multidisciplinary care. They're embedding themselves in the undergraduate and postgraduate level. And most importantly, these trainees are becoming the trainers. We don't work alone. So these guys are cognizant to the fact that we need other teams. So we in fact have a sister group that trains up nurses. And then within our group, we train rehabilitation therapists and currently technologists. Where does the rest of the world fit in? So we've alluded to collaborations. It can work really, really well, but I would encourage you to follow that guideline of how you do it best, thinking about the pros and cons. And cross-pollination and support across centres. So COVID kick-started this project for us. So we knew that Kenya was getting its own paediatric neurology training, but they were worried that they needed more upskilling in EEG skills. They were already doing a blended approach, working with the British Pediatric Neurology Association. So we created every 2 weeks an EEG interactive session where they present their cases and our trainees present ours. And then we discuss case management, implications, and interrogate each other on our definitions and approaches to care. And predictably, it's taken off, and now we've got trainees from all over the continent that are dropping in and joining the sessions. So let's think about what our aim should be when we're trying to actually improve things. So think about how you work together. So key points of coordination and planning, outreach and research projects. You need to have good contacts with the teams you want to work with. You need to be very careful about the areas of need that they are, that you're clear about what you want to do. And you need to understand what your infrastructure and capacity is before you leap in and do something too complicated. A coordinated team needs to be recruited. So you need to have the right members of your team to actually have the outcomes that you want. And that the training, you need to think about having the skills that you need, that's systematic and actually multi-targeted, and always making sure that your center is the one that decides how it happens and how it should come out, and that you have a sustainable support plan, and that you maintain your relationships in any collaborations that you have to your benefit, and to remember that you want to become the leaders in this. It doesn't happen without funding. And you should always monitor and challenge what you're doing and how you're doing it. I just want to let you know about another resource. So the ICNA is establishing an online learning tool called the International Child Neurology Teaching Network, and we've been running these webinars for free, and the courses are about to be rolled out. There'll be one in epilepsy soon. And just to thank you for listening and to encourage you to come to visit us in Cape Town. And if you love neurology, to attend the Congress that's going to be happening in Antalya in Turkey, face-to-face in October. Thank you.